Good night, everybody. I just started recording just to make sure that we're documenting what's going on with all of us. I'm going to mute myself in a few minutes because I have a dog and Malcolm in the background being more than what they should be right now. So I'm going to introduce Miss Michela Mondesir. She's going to be talking to us. I don't know, was there a title?
Talking about Nav1.1 and epilepsy.
Talking about Nav1.1, which is the sodium channel, the first of 9, and its relationship to epilepsy. So without further ado, Michela, you can share your screen and I'll put my stuff on you.
Let me just do this. Okay.
By the way, did everybody get a chance to get the article?
Yeah.
Yeah, I got it.
Where is it? Sorry. I found it again.
Ready? Michela?
Yeah, sorry. I'm trying to, it's not showing up on the, I'm not sure why. Let me try again. Oh, there it is. All right. Well, good evening, everyone. So I read this paper recently, and I figured I'd share what I learned about it with you guys. So if you guys have any questions, feel free to, well, should they hold it until the end, or, I mean, they can interrupt me if they want.
It's a small enough crowd that if you truly do have a question, you can stop her and ask her, because the whole object is for everybody to understand. It's not so much for her to present as more so us to get feedback about any questions that we naturally would have when seeing this presentation. So we're supposed to understand every slide before she moves on. I don't think she has a lot of slides. She has about 15 slides, and we have enough time to get through that. Keep in mind that Zoom wants to reset after 40 minutes. So when I get to 30 minutes, you'll get the notification that you need to finish within the next 5 to 10 minutes so that we don't get cut off.
Okay. I mean, if we do get cut off, we'll just come back, right?
Right, so they're right there. All right, go for it.
All right. So this paper was generally a review paper. So it was Catterall, Callum, and Oakley. Nice representation there. Catterall is like the #1 guy for sodium channels and ion channels on a whole. So if you're looking up any channels, more than likely you will come across. So this paper was pretty well organized. So these are basically just the headings for the paragraphs. So I kind of tried to summarize them. If you guys feel like I didn't, if you have any questions, of course, feel free to interrupt me. So we're gonna go through the voltage channel, sodium channels. And by that, I mean, we're gonna go through like the functions. So we know generally about the sodium channel itself.
Before you start, can you go back to the first slide so I can do the title real quick?
This one?
No, the first one, the title, that one. All right, I'm good, go ahead.
All right. So we're dealing with the associated sodium channels this time around. This channel generally has about 2,000 amino acid in its chain. Alpha units are about 260 kilodaltons, with the beta units being around 33 to 36 kilodaltons. So the chain goes through the membrane about 24 times. So we have about 24 transmembrane sections. And these sections are grouped up into 4 domains. So I have an example of a drawing of what it would look like. So these 4 beta voltage sensing segments, and 6 would be the pore. Just imagine they kind of just wrap, 1 through 4 just kind of wraps around 5 and 6. And of course, beta subunits over here. They're auxiliary, meaning they don't actually affect the function, but they do, if there is something wrong with them, that's when the function is kind of affected. So they don't really do anything when it's working. It's only when they're not working that they affect the alpha subunits. So there are about 9 of these in the family. The 1.1, 1.2, 1.3, and 1.6 are mainly found in the central nervous system, with 1.4 and 5 being found in the skeletal muscles and cardiac muscles, and 7, 8, and 9 are in the PNS. Well, no, they're in the dorsal root ganglion and such. Any questions if I move on? Anything? No? Take your silence as a no. So what do they have to do with epilepsy? Well, specifically, we're going to be looking at 1.1 because 1.1 is the one that is most ubiquitous in the central nervous system, and coincidentally also the one that will have the multiple mutations will cause epilepsy. So about 20 different mutations can cause generalized epilepsy with febrile seizures. Febrile being fever, so high temperatures will cause a seizure to will cause epilepsy to occur. And those 20 mutations generally just account for like just 10% of the seizure, like epilepsy numbers. And it's also associated with children with severe myoclonic epilepsy, which is kind of like jerks of the muscle. So it's not exactly a full seizure, but it can lead to that. So it's kind of like if your hand kind of just like this involuntarily. So de novo meaning that it's a de novo mutation, meaning that the cells, it kind of forms while the cells are dividing and forming. So that's why it's in children, because they're still growing up. So that's why it's more likely to see it in them than for it to just develop in adulthood. Although there are forms of epilepsy associated with adulthood. And just general like deletion and duplication of like the amino acids can cause epilepsy. So in that case, it's maybe like you've had a sickness. That's when it can occur in adulthood. So, I'm on. No. All right. So a little bit about the SME. It's drug resistant. So generally, it's really hard to treat because of its because of the channel that it's associated with, and it usually starts, of course, in the first year of life postnatal. So right after they're born, that's usually when it starts to develop. So it would start with just continuous seizures until it kind of forms into status epilepticus, which is basically just epilepsy, a seizure that lasts for more than 5 minutes. Usually they say that a seizure is usually easy to take care of. Well, not easy, but it's safe for them not to go to the hospital as long as it doesn't last 5 minutes, or if they don't have another one after their first seizure. So status epilepticus. So patients with SMEI, you will usually have status epilepticus, and they'd usually be hospitalized after their seizure episode. It's also associated with psychomotor delay, ataxia, cognitive impairment, because it can also affect the cerebellum. So, and I have the haploid in but somebody had a question. Hi, Carter. I actually can't see anybody's face. I just saw your name pop up.
Hi.
Right. So haploid insufficiency. That's kind of like when the chain gets cut short. That's the amino acid chain gets cut short, and that causes hypoexcitability, when in theory it should actually cause hypoexcitability, meaning loss of function, because we're losing out on stuff that can help with action potential. So in theory it should reduce the function, but for some reason it increases in function. It gains function, and I kind of go on to it is explained why. This whole paper is to explain, like, kind of to explain why that happens. So right here I have where all the different mutations of just Nav1.1 can happen, and all the different epilepsies that can that are associated with it. So circles are SMEI with, oh, you know, I actually forgot to put in what the symbols mean. Let me see. So circles are just missense mutations. So it's like, as in, if in the nucleotide, you know, in the amino acid, you know, is made up of 3 nucleotides. So if one nucleotide is changed in that thing, it makes a whole, it's like kind of makes a different amino acid. That's kind of like what caused that. So it's kind of like the wrong amino acid being in that place. And the triangles are in-frame deletions. So it doesn't cut it short. It's kind of like if there were like if there was proline, leucine, and glutamine in a chain, it kind of just takes out the leucine. So now you just have 2. It kind of makes the chain a little shorter. Not exactly like a truncation, which is the stars, which kind of just cuts the amino acid chain short. So imagine if there were like a whole, like say 100 after glutamine, and you just kind of take out that 100, and basically it can cause SMEI. So have all the different epilepsies that can occur if any of that happened. Red down here is that if truncations happen, it's mainly SMEI or SMEI borderline that occurs. And of course, there are a few, just like idiopathic, childhood epilepsy, which is, they don't know why it happens, it kind of appears. Yeah, so any questions? Any thoughts on what I've said so far? No? All right. So, on to what actually causes like the SMEI. And as the paragraph heading is, it's like it's caused by the selective loss of excitability in GABAergic interneurons. So for this experiment, they kind of used heterozygous knockout mice and homozygous knockout mice. So it's with one mouse has a parent who has the knockout gene, and one mouse and the other mice have both parents with the knockout gene, or rather they both have the knockout gene on both genes. Please tell me if I explain that right. So basically, what they say, what I have here is that the mice with only one of the genes died after 15 days, up to 17.5 days if they were kind of hand-fed. But by then they were basically, they couldn't do anything on their own. And the heterozygous mice lasted until day 21, the P means postnatal. After day 21, they started having like spontaneous myoclonic seizures. So day 2 just died. So while they did last longer than the homozygous mice, didn't really last that long. So that just means that any loss of this function for the sodium channel, sodium channel 1.1, is kind of lethal. So the voltage dependency, activation and inactivation in hippocampal neurons was not affected. However, in the interneurons of the same area, the current density was reduced in the inhibitory interneurons, but excitatory pyramidal neurons were fairly unaffected. And this reduction kind of caused, well, loss of high frequency action in both the hippocampal and cortical interneurons, which reduced inhibitory functions. So there was also loss of excitability in Purkinje neurons, which are also GABAergic. Purkinje cells are GABAergic inhibitory neurons. So if the GABAergic interneurons are affected in other places, then it is expected that they'll also be affected in other places as well. So since the Purkinje neurons are in the cerebellum deals with movement. If anything messes with it, it just kind of causes ataxia, which is kind of which is like loss of coordination, difficulty moving, that sort of thing. So homozygous mice, of course, had it harder than the heterozygous mice because they had it double. So they had severe impairment, while the heterozygous mice kind of had it just mild issues besides the spontaneous seizures after day 21. So in the Purkinje neurons, there are both the Nav1.1 and the 1.6. So as a result of the loss of the 1.1, whole peak, persistence, and resurgent currents are greatly reduced. Whole peak is just how far it could reach above at action potential. Persistence is how long it lasts, and resurgence is how long it takes to come back, basically. So how long it takes to open up again and how long it takes to close, because ideally the sodium channels should just open and close like in 1 to 2 milliseconds. It should be just instant, almost. So the loss of the Nav1.1 can reduce these currents coming to the Purkinje cell, because it's kind of like you just lost half of your current makers. If that makes sense.
I have a question.
Yes.
And this is not so much a question, but more so a statement that you can correct me if I'm right or wrong. So the sodium channel, it initiates the action potential.
Yes.
Right?
Mm-hmm.
And you're saying that there's a reduction in the current as a result of mutations in this particular channel.
Yes.
So that means that there is a decrease in the frequency of the action potentials? Is that what you're saying?
Yeah. Yes. Did that answer your question?
Yeah, you did.
Okay.
You're confirming me what I'm saying.
Okay. So this table just kind of gives you an idea of what's happening with the heterozygous and the homozygous knockout mice compared to the wild type mice, which are just normal mice. So in terms of percentage, in the hippocampal pyramidal cells, the heterozygous knockout mice weren't, in terms of the pyramidal cells, they weren't, both sets weren't too affected. So if you were to just look at the pyramidal cells, you wouldn't really see that there would be any changes. Because, I mean, there might be a little bit of a gain in function in heterozygous, but that's just a little error. So it's only when you go to like the interneurons that you start to see the major changes. So compared to the wild type mice, heterozygous knockout mice, they're only getting like 47% of the regular current, and it's even worse in the homozygous knockout mice, and where they only get like 27.5% of what they should be. And if the Purkinje neurons, compared to the wild type, at peak they're getting like 57 at persistence. It's kind of like halved. Homozygous is less than half, kind of around 40-30% of what they should be getting. And it's just kind of like the effects of what happens, the effects of the deletion of the 1.1 channel. So you have ataxia, fever-induced seizures, spontaneous seizures. So because the homozygous mice don't really survive after day 14, 15, they don't really get a chance to see them get fever-induced seizures or spontaneous seizures, because they're already dying. They already have like a premature death at like day 15 before they even get to have these symptoms. Question? Oh. Already? So yeah, I see it. These graphs here are basically just visual representations of what I was saying. So the circles are homozygous, squares are yes, forgot to also put the symbols for that one. So, let me check. Circles are wild type, squares are heterozygous, and homozygous are triangle. Yes. So, A is the A is in the pyramidal, and these are in the interneurons. So as you can see, there's really no change if you're looking, hardly any change when comparing it to the wild type. They look pretty normal. It's when when you get to here that you see that wild type is doing its thing all the way down. I don't know why the error bars are so big. I don't quite remember why. I didn't really state they're just really that big. When you look at the heterozygous and the homozygous, they're not doing too well. They're not even not that much current. They're not and potential is pretty low compared to wild type. So for B, well, A and B are together. C is basically clamp. So they're basically injecting 800 ms injections of depolarizing current. I really apologize for not putting all of that up in the slide. So they're showing like the wild type, the more current that they inject, more action potential is happening. And heterozygous, it's not slow, not much action potential. It kind of starts to look normal around 20 to 135, 40, 45, oh, down to 40. And 45 and down, it kind of starts to do the same thing. In fact, the peaks are not as tall as they used to be. Like, and there wasn't as many action potentials happening, but the peaks were still at least reaching their full potential to the full peak. But as you go down, even half of that until you get to 90, where you're really doing anything at all. And then D, this is in the Purkinje, the cerebellar Purkinje, the sodium currents, the wild type, reaching full potential. I guess about half that, total knockout, even about half of the heterozygous. So there's not that much. And density, in wild type, heterozygous, and total knockout, showing like low density and total knockout, as they were saying, in the wild type being normal. Any questions?
Get my phone. Get my phone. Go get my phone. Get off of him. Go get my phone.
All right. So we talked a little bit more about the fever-induced seizures in a mouse model, but it's just so children start to develop as their first symptom, and these are caused by haploinsufficiency, so truncations of Nav1.1. Just like, well, as I said before, it's like an incomplete channel. So the mouse models showing that they would develop it at, well, these are different mouse models because remember it didn't survive this long. It would start with febrile seizures, 17 to 18 days postnatal, and then they start showing all the symptoms, as in like SME, myoclonic seizures, all this of after. They'd be showing these symptoms just after a few days. So that's when they start, like I said, myoclonic seizures with generalized seizures with fevers. Something I didn't mention before, but I should have. So 1.1 and 1.3 are generally, 1.3 is generally more ubiquitous than 1.1 at the embryonic stage. But when the mice are born and they start to grow, 1.3 is replaced with 1.1, or at least they should be, because in the knockout, there's nothing to replace them. So as the mice grow, the 1.3 reduces, and the 1.1 is either not taking up what it is not doing its job because it's not there. So that's generally why after a couple of days, even if it's just like days, die or basically show a whole bunch of symptoms. So I'm gonna stop here for now, and then we're gonna restart the meeting. So
Yeah, you have about 1 minute and 40 seconds left. So we're gonna start, and I'm gonna reinitiate the meeting.